Right, good afternoon everybody. My name's Lisa Jelly. I'm the NHS Service Manager for the Integrated Care Clinics. Today I'd like to present to you our service model that we currently run across the Wyre CCG. It is about improving accessibility and specifically about bringing MSK clinics closer to patients' homes. So just a brief introduction to the company. So the Integrated Care Clinics, formerly known as the Injury Care Clinics, was first established in 1996 and has since grown to become the UK's largest private provider of physiotherapy, diagnostics and rehabilitation services. More specifically with the NHS, over the last 5 years we've grown and strengthened that relationship, and we currently deliver treatment and triage services across 37 CCGs. Mainly through any qualified provider contracts, but also through sole provider contracts. We deliver on an annual basis over 600,000 physiotherapy sessions, of which just over a third of these are now on behalf of the NHS. With commissioners that we work with currently and with future areas, future CCGs, we like to work in collaboration with the commissioners, with lead MSK practitioners, head GPs, in terms of providing innovative ideas as to how we can improve patient care, how we can improve access, how we can improve the service users as well, so GPs referring into the service, and also try and reduce costs. So specifically with the Wyre CCG, so just a brief overview in terms of the service before we came in. There was an average wait of 16 weeks for outpatient physiotherapy. The DNA rate on average was 14%. Appointments usually were between Monday and Friday and started at 8:30 and finished at 4:30 or 4 o'clock. And they were all based very centrally in the hospital. There was very limited patient satisfaction data that the CCG could provide to us, and very little outcome data. The physiotherapy department seemed to work in isolation. There was very little integration with other primary care services like podiatry teams and other secondary care services like the consultants. And there was also very little sort of shared best practice. There was very little GP upskilling by the physiotherapists, by the ESPs. And it was basically non-existent in terms of interoperability. So sharing patient data, sharing patient records didn't really happen very efficiently, which unfortunately would have meant that patients would have had to go over their previous history of a condition, depending on who they were seeing along their patient journey. So we initially came in as a community physiotherapy provider. From getting feedback from the CCG, from doing patient focus groups, we found out that the main problem was the fact that patients were having to travel to this central point. And sometimes that involved 45 minutes on public transport. So what we did is we provided an in-house clinic. So there are 12 GP surgeries in the CCG, and we provided a clinic in 11 of them. What we also tried to do is integrate our service with other MSK pathways. So we met with the podiatry teams, we met with the consultants, we met with the radiology teams to try and establish what their referral criteria was, what their waiting times was, what information they needed from us if we were to refer into the services. And that meant that we could say to patients when we referred how long they needed to expect to wait. And they were fine with that as long as they had that information. It also meant we could provide the right details on the referral form to prevent referrals bouncing back, and it ensured that we sent appropriate referrals through. We looked to upskill all of the GP practices. So of all of the surgeries, there was only one GP practice that didn't actually engage with us, and we managed to do a syllabus of MSK education with every single GP surgery. And after we managed to get through the door, which took a while, and started to do breakfast meetings and lunchtime meetings, we started to do education sessions that were very specific to what the GPs wanted. So rather than me go in as a physio and talk for an hour about how I assess a shoulder for half an hour, because that's a luxury I get, it was more how to assess, diagnose, make an onward referral, give any self-management advice, all within about 7 minutes. So that's what GPs get, so that's what we try to tailor the education session. We launched specific rehabilitation services. So we found after a while that we got a lot of patients coming in with, say, OA knee. So we put on group exercise classes, for specifically OA knee patients, so they could come and do exercises amongst their peers, have discussions, and actually do some informal education as well with those patients. Gives them coping strategies, pacing techniques, that sort of thing. And that bridged the gap between having one-to-one physio and then being discharged into their own home and being able to carry on those exercises themselves. Finally, we had feedback from the GPs, which was saying that they felt like there was a gap in the actual service. They felt there was a gap in the actual MSK pathway where complex MSK patients, normally they wouldn't really know what to do with those patients, and they'd have to send them into the consultants because that was the only place for them to go. They didn't want to send them into community physio because maybe they'd had that before and it hadn't worked, or they felt that this patient might need some sort of diagnostics, might need an injection. The GP wasn't skilled in that area, so they sent them on to secondary care. What they felt is they wanted somebody, an expert clinician, who was actually working within the practice that could offer that service. So they approached us with that. And we ended up putting ESPs, so extended scope practitioners, who were trained in sonography, trained in peripheral joint injections, had that expert diagnostic skill in order to be able to diagnose these complex MSK conditions, but also coordinate with other areas. So they understood the medical management side of things and could work with the GP in terms of getting any blood workups done, for instance, but also knew when to send on to secondary care or diagnostics, or when to self-management, inject within the clinic, or send out to community physio. So we decided to put these ESPs as a pilot into 3 of the main surgeries in the area. And they only worked for a day or half a day a week, and that was what the capacity required. And we ran that for 12 months. That was the model. So a bit like I've just described there, so they're that core part of the MSK pathway, having that expert clinician for the patient to see right from the start of their treatment, which ensures that they get the right treatment at the right time, right from day one. So we ran the model for 3 months to start off with, and we managed to get quite significant data coming through. We saw a big reduction in those secondary care referrals because those GPs had a place to send those patients to. Based on the initial data, it was predicted that we would save £200,000 if we rolled out this service across the entire CCG. The CCG were the ones that actually established this, so they were then quite keen on rolling it out across the whole area, which we did. And the whole thing was tying into, again, bringing this patient care closer to the patients' homes. The service itself ran from Monday to Friday, 7 a.m. till 7 p.m, and occasionally on Saturday mornings. So effectively, these ESPs were acting as GPs. So in terms of the results, initially, as I said, there was a 16-week wait for physio. That ended up coming down to 1 week. We managed to reduce the DNA rate down to below 6%. There was that 40% reduction in scans and the 45% reduction in secondary care referrals. But what's probably most important is following that patient journey on that one step further. And of the secondary referrals that we did make, actually 95% of them were appropriate referrals. So those patients did go on to have some sort of secondary care intervention, some sort of surgical intervention. And we managed, other than one surgery, we managed to actually upskill all of the GPs in the region once word got out that actually it was a useful session to attend. In terms of the specifics then, care closer to the home, we had 11 clinics across the area, mainly GP surgeries, but also a leisure centre, so we could have the extended hours. We were open from early in the morning through to the evening, so patients had the choice of being able to access an appointment when they wanted to access it, and that was one of the main things that led to our DNA rate reducing. The Saturday mornings was actually initially quite challenging to fill. We have opened some Sunday clinics before, and they were not popular at all with patients, which I'm sure other people have found as well. But we still continue to open our Saturday morning clinics when needed. And more recently, we've had a patient portal, which is actually very specific and individual to each patient. They have access to this online service where they log in through their own password, and it's tailored to their injury. So it welcomes them as a patient, and we can actually spy on them. We can see how often they log on to this portal. And if we can see that there's maybe been a drop off to how often they've logged on, and then suddenly they call back in saying they want more treatment, we've got that link to then ask them, maybe go back and try the exercises, the videos that you've got access to on that patient portal. In terms of patient experience, in 2014, we completed 65,000 sessions. There was a 20% sample rate where we actually did a survey. Friends and family, 98% said they would recommend us, and 97% say they were either satisfied or very satisfied with the treatment and the service that they received. In terms of the referrer experience, this is specifically the GPs here. They felt that that gap had been bridged. They had that access to the expert MSK clinician that they really wanted. It helped with collaborative working. We were working in-house with the GPs. So often the GPs would come and knock on our door and ask for advice whether this patient should be referred into the service, and we could speak to them about any medical management that we felt might be needed. That facilitated shared decision-making, not only with ourselves and the patient, but also involving the community physio teams and also the GP. And the GP uptake in terms of the CPD sessions was very high, and we've had very high feedback, and they're still asking for more sessions now. We've pretty much gone around every single joint in the body, to be honest, with most GP surgeries. So in terms of the future, due to the success of the pilot over that 12 months, it has now been commissioned and is now rolled out still across the whole CCG and is still working today. We want to continue to make sure that patients are feeding back to us, and that is moulding the service that we do. The Wyre CCG in particular has got a very elderly patient population. 21% are over the age of 65, which is 5% higher than the national average. Because of this, we know there's a high demand in the area for care, MSK care, due to the prevalence of long-term conditions, complex MSK conditions. So we need to make sure that patients still have access to this high-level MSK clinician, and that's what we want to do, and that's what's going to be the best for the patients. That's it. Oh, sorry.
That's okay. Thank you very much indeed. I know you were particularly nervous about that. That was well done.